Thank you. I voted for the beanie. So, it's a great pleasure to introduce our after lunch speakers. We've got another amazing series of people that hopefully will also provide a continuation of the fantastic morning we've had. So our first speaker for after lunch is Dr. Matthew Johnson. Matthew Johnson is at Johns Hopkins University School of Medicine. He's a scientist, psychologist, and he is currently the Susan Hill Ward Endowed Professor of Psychedelics and Consciousness Research at Johns Hopkins. That's a really one-of-a-kind title. Working with psychedelics since 2004, he's one of the world's most widely published experts on psychedelics. He has published research on psychedelics and mystical experience, personality change, tobacco smoking cessation, cancer distress management, and depression treatment. In 2021, he received, as principal investigator, the first grant in 50 years from the US government for a treatment study with a classic psychedelic, specifically psilocybin in psychedelic-assisted therapy. Please extend a warm welcome to Dr. Matthew Johnson.
Thank you so much, Elizabeth, and it's so great to be here once again at Horizons. It's been too long, and so thank you all for kind of gathering here, finding the room. I had a little trouble finding the room, actually, off the bat. I came here, and apparently there's this other meeting, a dermatology meeting, and I was looking to get mic'd up for the talk, and I showed up in it was a little room. And I said I was trying to talk about using mushrooms to quit smoking, and they were really confused. And someone said, Matt, why would you think it was in this room? And I'd say, well, everyone else is in the big room, but I figured the smallest room in the house is the mushroom, right? Too much of a build-up for something so lame. Okay. I'll take the jeers. So I'm going to be talking about classic psychedelics in the treatment of substance use disorders. My colleague Sandeep is going to speak after me, more particularly on our line of research, which we've been pursuing for well over a decade at Johns Hopkins, using psilocybin to help people quit smoking, to address tobacco addiction. But I'm going to give you the more general layout here. So this is why we kind of switched the order of our speaking from what was in the program. All right, so first, before going any further, just to disclose some advisory relationships I have with companies developing psychedelics or analogs as medicines, but I'm not showing or speaking about anything that's directly relevant to those companies or their work. So this audience probably knows psilocybin is the active agent in over 200 species identified at this point of so-called magic mushrooms, mostly in the psilocybe genus. Of course, it's in that same pharmacological class as LSD, mescaline, and dimethyltryptamine, being a classic psychedelic, meaning their shared primary mechanism of action is serving as agonists at a subtype of serotonin receptor, serotonin 2A. And of course, we're in the midst of this renaissance, this resurgent, this age of enlightenment of research with classic psychedelics. After it really dropped off in the late 60s, early 70s, largely due to sensationalism and some casualties, but also sensationalism surrounding and leading to the conclusion that they couldn't even be used safely in medical and psychological research. But we're in the midst of this renaissance that's been going on for about 2 decades, and I'm showing you just some evidence of that. The scientific papers with psychedelic or hallucinogen in the title, just stable for decades and then skyrockets. Around the time I got involved with this research in 2004, it started to uptick. So this has largely been instigated by some really promising therapeutic findings so far. We could say a lot about the harms of these classic psychedelics, and there certainly are some. We know a lot about that. I won't go into those in detail. I've published some key publications reviewing that literature in 2008 and 2018. I'll refer you to those. But one area of potential risk that I will mention here that is generally there for most drugs of abuse that's not there for the classic psychedelics appears to be a potential for addiction. So even though people can use psilocybin or LSD in dangerous ways, and in that sense they can be abused, there's really no evidence suggesting they themselves can be drugs of addiction. In other words, they don't lead to compulsive drug seeking. And we know that through every possible level of scientific evaluation, whether it's the way they work or in fact they don't work in the brain's mesolimbic rewards pathway. We know that from the large-scale survey epidemiology, as long as you're making sure that they don't include other drugs like PCP and ketamine in there from other drug classes. And we know it from reliable animal models, the rats pressing a lever to get the injection of the addictive drug. So by all of those metrics, these do not look like drugs of addiction. They're not very good reinforcers. The behavioral model of all of the treatments looks like this. So in our substance use disorder work, as well as any of our other therapeutic psilocybin research. So this is a mock participant laying on a couch while the two guides or monitors are there in the session, mostly to provide psychological support if distress, if some distress pops up. So I've gone over why we wouldn't expect people to be, hooked on their psychedelics, their psilocybin, but why would we expect these types of drugs to treat addiction? After all, these are drugs of abuse, right? So I'll describe some of those rationales, and this really is the meat of what I'm going to talk about. First, there's this body of work in healthy normals suggesting, even though these aren't people looking to quit an addiction, several anti-addiction-like mechanisms have been found. In our early work with psilocybin and healthy normals, we found that people had claimed, as well as community observers claimed, that participants saw improvements in quality of life over a year after sessions, and made claims of positive behavior change. Now that's kind of vague because, again, these people didn't come in with a common problem to treat, but there were these claims of behavior change long term. And then this other healthy normal study we did at our group looking at psilocybin in 4 different active doses of psilocybin, we found orderly effects on a whole host of long-term positive outcomes, including claims of positive behavior change. Something else that shook out of both of those first 2 studies when you combined the data and had that increased statistical power is that we found that high doses of psilocybin led to an increase in this personality domain called openness to experience. And this is one of the so-called big 5, sort of these major domains of personality, these personality domains. And openness to experience refers to a tolerance for different points of views, the ability to hold multiple points of views at the same time, and appreciation for aesthetics, including art. We did find that that psilocybin increased personality openness, and the remarkable thing about that is that, to our knowledge, this was the first demonstration ever of a relatively discrete laboratory event that can actually change a personality construct. I mean, the definition of personality is it's stable. It doesn't change much. It might change over the decades of your lifespan, but it doesn't change very dynamically. And so now this has been replicated by other groups as well. So that openness to experience, I think, fits extremely well with undergoing addiction recovery for any drug you throw at it. And this was, in that healthy normal work, this was driven by not just whether you got the psilocybin or not, but whether you had a so-called mystical experience or not. So people had the same dose of the drug that didn't have the same type of subjective experience as the mystical experience, did not see that increase in openness. Mystical experience sounds like a woo-woo kind of out there term, but actually refers to a pretty well-described psychological construct going back to William James over 100 years ago. Was just fascinated outside of drug use that many extraordinary human experiences across the centuries from different cultures share remarkable similarities, such as someone feeling an overwhelming sense of unity, positive mood, transcendence of time and space, and ineffability. And so we've done a lot of work with this construct in terms of psilocybin drug effects, and have found in a number of ways that it's predicted long-term therapeutic results. So some of that healthy normal research is suggestive of, again, a therapeutic efficacy. So now another category of why we would expect psychedelics to help is the anthropological literature suggesting that ceremonial psychedelic use is linked to addiction recovery across a number of groups. So peyote use in the Native American church, and also ayahuasca ceremonies in South American indigenous cultures, as well as syncretic South American-based religions. There are a number of these reports of people claiming that they stopped or substantially reduced their use of addictive substances because of their use of the psychedelic sacraments in these settings. Of course, we know religious involvement in general is associated with addiction recovery, so you got to take that with a grain of salt. It's observational afterwards, but the final leg of evidence is that older work using LSD, going back to the 1960s, using LSD to treat alcoholism. And some clarity was brought on that older literature, which had been sort of concluded to be sort of a mixed bag. Some studies found significant improvements in alcoholism, some didn't. But clarity was brought by this meta-analysis about a decade ago, where they looked at only the 6 studies that randomized LSD, people to either LSD or some other drug condition. Some other condition, not necessarily a drug condition, but some other condition. And anything to the right of that line in the middle at 1, as you're seeing on the screen now, would indicate better outcomes for LSD. And in fact, you found that trend for every study, and it was significant for a subset of the studies, and in aggregate, as represented by the diamond at the bottom, all of the studies showed a statistically significant effect. More important than statistical significance is what we would call effect size. Essentially what that means here is that LSD essentially doubled the odds that a given patient would be improved at the first follow-up time point, which is a big effect and rivals anything we have today. So it should have been pursued long ago. And there was some other work using LSD to treat heroin addiction. So this was a study published in Baltimore, actually, where I do my work. They used LSD to treat heroin addiction. There were some limitations. The LSD group, it was randomized, but the LSD group then had they had a short inpatient stay that wasn't there for the other group. So there's some limitations. Nonetheless, there was biological verification of urine to verify abstinence. So that was pretty rare back in the early 70s. So some real strengths. And they found another strength is that biological verification at long-term outcomes. So at a year later, they found significantly higher abstinence in the LSD group, biologically verified by urine. So pretty encouraging early results. And then our group, we published a series of studies, really just survey studies, really kind of prompted by a lot of people coming up to me and asking, when I present some of the work on smoking cessation, folks might say, oh, this happened to me 5 years ago, 10 years ago, 30 years ago. They took something typically just for fun, and then they ended up deciding to quit or to smoking or drinking, using cocaine, what have you. And so we've documented some of those stories in the literature. So that's those sort of stories, anecdotal stories, are also suggestive. So then moving into the modern era, I'll let Sandeep tell you about our smoking cessation research, but certainly very promising parallel work that's been conducted by our colleague Michael Bogenschutz, now at New York University, who published this when he was in New Mexico, published this really promising pilot data. It's an open label study in 10 individuals with alcohol use disorder, showing reductions in drinking days and heavy drinking days by self-report. And so how do you explain all this? It's challenging enough to explain how this stuff works across these different forms of addiction, but I haven't told you, and you're probably familiar with, is work suggesting it helps with depression, cancer-related distress. How in the world is this stuff working? Michael Pollan credited me with the very unscientific sounding name of the dope slap effect. He's like, Matt, how does, after like 3 glasses of wine, he's like, how does this work though? What is it? And I'm say something like, it's like they're just dope slapped out of their story, whether they're depressed or whether they're a smoker. So, I can't do it, I'm a failure, blah, blah, blah. Like, just, they're like blasted out of that sort of like very narrowed perspective. for these different disorders, and hopefully we can fill in more about that. But essentially letting go of these mental models that they use to organize reality. So we're doing a number of studies now. I won't name them all, but for sake of time, but certainly in terms of substance use disorder treatment, hopefully within the next month or two, I'll be starting a study using psilocybin to treat opioid use disorder. We have an ongoing study right now that Fred Baird is leading, treating comorbid major depressive disorder and alcohol use disorder. And I'm also going to be starting a study with LSD to treat chronic pain with the eye towards minimizing or eliminating opioid use if possible, so sort of tackling the opioid epidemic from that angle. So I think, yeah, that's all I'll mention. And then finally, as was mentioned a little bit, as Elizabeth mentioned in my bio, you're going to hear more about the smoking work here, but we're super excited about that work because after all of this time, and they're looking, 13 years ago when we started, like there was no hope, like we actually landed a freaking like federal grant to look at the therapeutic effects of psilocybin in smoking cessation. So we're just super excited about that, and I will then leave it to Sandeep to fill you in on that smoking cessation work. But I want to thank just an amazing and growing group that you saw very briefly up on the slide at Hopkins. So thanks to the team and thanks to you all.
Thank you, Matt. Our next speaker is Dr. Sandeep Nayak. Sandeep is a psychiatrist and postdoctoral fellow at Johns Hopkins Center for Psychedelic and Consciousness Research. After receiving his MD from Brown University, Dr. Nayak completed his residency in psychiatry at Johns Hopkins Hospital. He's primarily focused on investigating psychedelics as treatments for psychiatric conditions, particularly substance use and mood disorders. Dr. Nayak also works as a clinical psychiatrist at the Addiction Treatment Services at Johns Hopkins Bayview Medical Center, treating patients with co-occurring mental illness and substance use disorder. Please welcome Dr. Nayak.
Thank you so much. Can you hear me okay? Okay, so yes, I'm going to be discussing psilocybin-assisted therapy for tobacco smoking cessation, and this is one of the more compelling use cases, in my opinion, of psychedelic therapy, and I hope you'll see why. So the learning objectives are quite simple. So we're going to first review the context, which is that smoking remains quite a deadly blight upon our society. Existing treatments do not work that well, and I'm going to show you some of the data for this. And with that background context, we're going to review the Hopkins data of psilocybin for smoking cessation, as well as talk about some future directions. So essentially, since big tobacco propaganda notwithstanding, it's been recognized essentially since the introduction of tobacco to the Western world that it's quite harmful. And so this is King James of England writing at the turn of the 17th century. It's a custom loathsome to the eye, hateful to the nose, harmful to the brain, dangerous to the lungs, and in the black stinking fume thereof, nearest resembling the horrible Stygian smoke of the pit that is bottomless. And I couldn't have said it better myself. And that's a few hundred years ago, and yet to this day, it's really hard to overstate how deadly this still is. Smoked tobacco is still the leading cause of preventable death in the US. 14% of US adults smoke regularly. The vast majority of people want to quit, and the narrow majority attempt to quit in any given year, with most quit attempts being unsuccessful. And again, this is a drug that kills half of its long-term users when used as intended. So globally, about 12% of all adults will die. Tobacco will contribute to their death. And this is there are different risk groups. For example, men are much more likely than women, and there are other risk groups as well. So tobacco is very bad. That's kind of the take home. And the second part of that, though, is that existing treatments, which do work, are not very effective. Now, I want to actually walk you through some of the data so you have a sense of this. So these are various drug treatments, and we're looking at 6-month abstinence rates, meaning people not smoking. There's different ways to measure this, but in order of efficacy, we're looking at long-term nicotine patch plus ad lib. So for example, gum or lozenges nicotine. And that's almost 40% people have quit at 6 months. Varenicline and bupropion, these are daily pills. They're less effective. Short-term nicotine patch is even less effective. Placebo is abysmal. Nothing's really breaking the 40% line. But this is easier to show visually. So we're looking at a meta-analysis of 13 nicotine patch trials. So blue is nicotine patch and red is placebo. And these are largely short-term interventions that then stop, and then you have a follow-up period. So at the end of the intervention, you can see that 40% of people have quit, and then it decays over time, placebo doing worse. Different drug, we're looking at bupropion trials at 6-month and 12-month follow-up. Again, it's about 40%. Doesn't really cross that mark. Placebo's doing worse. Varenicline plus a couple of different nicotine replacement schemes. Again, at 1-month follow-up, it's about 40% for all of them, and it declines over time. And just same 3 figures together, one of the things that you notice is that there's almost like a ceiling. You don't see these treatments breaking that 40% mark when you look at long-term follow-up. Now again, these are all short-term treatments that then stop, and then there's a follow-up period. So there is a study that looked at, well, what if we just continue administering some form of therapy over a long period of time? And so Hall et al. 2009, they did 3 months of bupropion plus nicotine replacement plus counseling, and then afterwards, a group stopped. They got no further treatment. Another group got nicotine replacement for a year, and then the final group got CBT intervention that was quite expansive, including mood, weight management, social support, et cetera. Really an incredibly resource-intensive intervention. And as you would hope, the groups that continue to get some form of therapy actually did better. There's that 40% ceiling. The standard group did eventually fall below that. But resource-intensive, continuous treatment was able to do quite a bit better. So the general gist of this, though, is that by and large, normal treatments, the way that they're typically used, don't really do that well in the long term for most people. So enter psilocybin. So this is the pilot study out of Hopkins, led by Matt Johnson, of psilocybin for tobacco addiction. And this was 15 people. They were smoking about a pack a day for roughly 30 years, and everyone had had multiple quit attempts, average 6. So this is an uncontrolled study. So these are all people that know that they're getting psilocybin. They're not being compared to anything. It's a 15-week intervention. It starts with a month of CBT for smoking cessation, and then they get multiple doses of psilocybin, 20 to 30 milligrams per 70 kg. So these are quite large doses. And it follows typical preparation, dosing, integration procedures, as Tony Bassis described in his excellent talk. So similar figure to what I've been showing you, but basically the gist here is that in this group of 15 people, open label, it's roughly 80% abstinent rate up to 6 months, and then it declines to around 60. So quite a bit better. But again, this is an uncontrolled, small study. Take it with a grain of salt. And like in other studies, this measure of mystical experience correlates with a biological measure of smoking cessation. These abstinence numbers are biologically verified. So anyway, there's a bunch of critiques of psychedelic clinical trials. So just to paraphrase, people might say, you're giving people these powerfully subjectively acting drugs. Essentially, people know exactly what they're getting. They're unblinded. And the placebo group, maybe this is even a nocebo group. Perhaps a lot of this is being driven by expectancy effects. And these are all actually valid critiques. But in the example of tobacco, you have a variety of existing treatments that you know work better than placebo, and kind of a good sense when you administer a short-term treatment about how well it does over the course of 6 months. And so I'm going to speed ahead a bit. In this ongoing comparative effectiveness trial, so basically people know what they're getting. You have 4 weeks of CBT, they get randomized, and one group gets psilocybin, the other group gets a typical course of nicotine patch. They both get substantial social support. This is a single dose of psilocybin. And then the intervention stops. You have 3, 6, 12-month follow-up. Yeah, they're smoking about a pack a day for roughly 30 years, 7 quit attempts, kind of same thing. So anyway, the basic gist is that at 3, 6, and 12 months, you see psilocybin, roughly around 50% of people have had enduring abstinence, and the nicotine patch, it's again around 40%, and it decays over time. And so by the 12-month mark, there's quite a large difference. And again, these are just short-term interventions that stop. Comparing this to what you've already seen, Hopkins is in the center. Again, psilocybin is red, nicotine patch is blue. The other 2 figures you've already seen. So you notice that the nicotine patch group actually does perform about as well as you would expect from other trials. And so this probably is a fair comparison, and psilocybin seems to be doing better than these other treatments. And then Hall et al., this one, they used really resource-intensive ongoing therapy. They were doing quite a bit better, but again, this long-term enduring effect of psilocybin. So I haven't really gotten too much into the effects, but let me just state the obvious. This doesn't work similarly to other smoking cessation drugs, and the kinds of effects and the kinds of subjective effects you're going to see in this population is going to be quite similar to what you'll see in other psychedelic therapeutic clinical trials. And people may have any number of things like mystical experiences, psychologically insightful experiences, altered sense of self, develop emotional or cognitive skills like mindfulness. I'll just kind of read out one illustrative example. This was one of, if not the most profound experience of my life. Not only did I see God, but I experienced a sense of unity and love like I've never experienced before. Not only could I see it, but I could feel it. I could almost taste it. It was thick and intense. ... Cigarettes no longer feel like a part of my daily life, and my urge to be healthy has overtaken my urge to smoke. I saw my body being cleaned out of all the impurities I have placed in over the years, and I'd like to continue to keep it that way. And I think we're almost out of time, but there's quite a lot of idiosyncratic responses to this, and there's a huge range in terms of the effects that people experience, and there are many ways that this seems to be helpful for people. And then future directions, so I think we're probably out of time. We can maybe tackle that in questions. Thank you.
Thank you so much. I'm going to invite Matt Johnson back up, and we'll do a couple of questions for both of you, and probably touch on your future directions therein. You're welcome to sit or stand, whatever is more comfortable. So I'll start with a couple of questions, and then anybody from the audience that would like to ask a question, if you can go to the mic and line up and get ready to ask a question that is a sentence that ends in a question mark, that would be fantastic. So actually, my first question is for Sandeep, which is, what common factors do you see between the way psilocybin works for smoking cessation and the way that it works for other indications?
So, I guess one way of thinking about psilocybin, it's not the only way of thinking about psilocybin, is it's this intervention that seems to work transdiagnostically, that seems to exert its effects through subjective experience. And in that way, you can conceive of it as a psychotherapy. And all psychotherapies share certain features. Psychotherapy we know works for smoking cessation, for example, but I don't think there's any one silver bullet aspect of it. It's people have re-narrativization. Perhaps they no longer see themselves as a smoker. They develop new emotional or cognitive skills that allow them to cope better. People describe, for example, being able to experience craving or craving with sort of an open curiosity rather than this compulsive sense. Those are only small tidbits, but I think there's a variety of ways that it overlaps with other treatments. I don't think this is like uniquely anti-tobacco intervention.
Yeah, thank you. I like that word, re-narrativization. I hadn't heard that one yet, but it's really great.
It's a good one.
Yeah, I think you nailed it. Is that a new word? Is that your word, or is that?
I'm gonna just say I made it up.
You should coin it.
I think you just coined a word.
It's like 7 syllables, I thought.
Yeah, there you go. Okay. So when you write papers and you write about the concept of re-narrativization, remember where you heard it first.
Yes.
Next, I want to ask a question for Matt. Presuming that all goes well and your studies show what you might expect that they would show based on some of the pilots, and your new approval for additional research on smoking cessation, what do you imagine it would look like for patients in the community to be able to actually access psilocybin-assisted treatment for smoking cessation? I assume you're not just going to like go into CVS and buy it from behind the counter like a nicotine patch, right?
Yeah, so it's
Yeah.
not, I like to say, it's not take 2 and call me in the morning. Take 2 caps, maybe a stem and a cap, call me in the morning. No, it's not. So it's okay. No more jokes for me. That's my last try. That's my last try. Yeah, so to put it succinctly, I think it's going to look, the treatment model should look very much like what we and our various colleagues at all the other institutions doing modern research, the way that they're doing these clinical, these therapeutic studies, minus a bunch of the questionnaires, which is a lot. I feel like people get hand aches after filling out all the questionnaires, but like you have to have the preparation. It's going to look in that sense like and you have to be a loved one pick you up at the end of the day, so it's like outpatient surgery in that way, so you're prepared for it. It's like you've got this super intensive monitoring during the actual experience, like an endoscopy or outpatient surgery. So, and that's the thing we have to watch out for as this stuff is being commercialized, and there's a lot of interest moving it forward, is that we don't whittle down the safety factors, including the preparation, too much. And where that line is, we don't know. And it's not evil to come up with a more disseminable treatment that's going to be cheaper. It means you're able to help more people. That's not a bad goal, but we've got to be based on the evidence and figure out how to do this safely and not reduce those safety factors too much.
Excellent. Thank you. Well, I look forward to the day that if this is demonstrated to be safe and effective and possibly great treatment, that it can really be helpful for a lot of people. I'd like to open up to a couple of questions from the audience. What do we have? Okay, we'll pause.
Okay, that's good because I have a quiet voice. My name is Abigail. I'm a graduate student in doing a master's in counseling. And I was just wondering if you plan to look at using psilocybin to treat process addictions, and if you have any thoughts on that in general.
What addiction? I just missed it.
Process addictions or behavioral addictions, not substances.
Yeah, great. Do you want to take
So
that?
yeah, I mean absolutely. Stuff such as obesity, gambling disorder, very sexual disorders. A bunch of people have actually just reached out about that, and it's like, we don't have a study in a self-proclaimed sex addiction, things like that. I think there's a huge potential. That transdiagnostic core that Sandeep was describing is that's the recipe for it working, not just in different forms of drug addiction, but different forms of addictions beyond the drugs. So, you have to wait and see. And I think a bunch of other groups have the same plans, but no work that's kind of progressing at this point.
But if I could widen this from process addiction to disorders of motivated behavior, I mean, there are anorexia trials going on, and so there's no reason in principle why this couldn't, be applied to various behavioral disorders.
Great.
Thank you.
Thank you.
Hi, I'm Eric. I'm a licensed clinical social worker at Kaiser in the infectious disease department at Los Angeles. That was a lot. My question is this. Unfortunately, so many of my patients suffer from methamphetamine addiction. Is there any hope or promise using psilocybin to treat that? Thanks.
Yeah, I mean, wait, isn't there a methamphetamine trial going on somewhere?
I like that we're at the point in this psychedelic renaissance where we're like, has someone started that yet? I'm not quite sure. I think I've heard rumblings, and I'm not quite sure. I don't think so. Of course, there's cocaine that Peter at UAB is doing, but I don't think anything's going on with. What's that?
Oregon is doing one with that.
Oh. Okay. Thank you.
There you go. Again, I mean, there's no reason. We don't think that there's anything drug-specific about the way in which psilocybin could be helpful, and so it stands to reason that perhaps it could be useful. Those trials need to be done. It's ultimately an empirical question, but I think it's a very valid line of inquiry.
Thank you.
Thanks.
Rami Vital from Universal Ibogaine. So congratulations on your success to date. My question is this. Some people smoke to deal with mental health issues, depression being one, psilocybin being effective, according to your research in mental health, in dealing with depression. How do you control for this when you're dealing with tobacco use disorder? How do you make sure that you're not actually treating the depression, and that's why these patients are getting off smoking?
Thoughts?
Well, I think that one way, there's two ways of thinking about this. One, I mean, you can just look and see if these people are not being recruited to have major depressive disorder. But two, again, this is a transdiagnostic, not domain-specific treatment that we think can exert its therapeutic effects in a variety of ways. If psilocybin can reduce tobacco smoking through the mechanism of improving mood, I think that's actually good. But it's not the case that the majority of these people are depressed.
There's a possibility that short of like full diagnosable major depressive disorder that, well, I mean, it is known that smoking does play a role in like emotional regulation. So there might be some connection there transdiagnostically with affective processes at play in addiction, but at this point, it's like in terms of teasing that out, since you're talking about like mood that's not meeting the level of depression, it would be really hard to tease out. Yeah.
Makes a lot of sense, and don't let that stop you. Thank you.
Thanks. One more? Let's do one more.
Hi, I'm Andrew. I'm a journalist. My question is for you, Matt. You say psychedelics can cause harm in people with psychosis. My understanding, is there evidence for this? My understanding is that is anecdotal at this point.
Yeah, it's anecdotal. And so it's one of those weird things where it's sort of, it's the clinical observation just over decades of people showing up to the emergency department, the types of stories of, so-and-so went on a trip and never came back. And when you dig in descriptively, the typical, almost in virtually every case, it seems to be a pattern where someone was either suffering from the early stages or at some stage of some major disruptive disorder like schizophrenia or another psychotic disorder or mania, or they showed a clear predisposition in their, at their previous behavior. I always think of like Syd Barrett, the first Pink Floyd singer. It looked like he showed the signs of, premorbid schizophrenia before he started taking lots of acid. So I think we know too much at this point based on essentially anecdote. We know so much that we couldn't ethically do a study. I could say, give me, 50 people that are showing early signs of schizophrenia that haven't been fully diagnosed yet, and give them, LSD and randomize another 50 people to get placebo. It's like we know too much that would be unethical to do because it seems there's enough of a risk that's likely there. And the last thing I'll say is you've never seen this in the tens of thousands of patients that either in the earlier era of medical research from the 50s to the early 70s or the modern era for about 20 years now. So these cases, they just aren't showing up in these cases where we're screening people for those disorders. So that adds to the anecdote. It might be more than anecdote, but it falls certainly short of any strong experimental evidence.
Thank you.
You're welcome.
Thank you so much, Matt. Thank you so much, Sandeep. You guys have brought us an amazing amount of research and really Thank you for your time. It's been great.
Thank you.